Hello, welcome to Indonesian Society of Interventional Cardiology at TCTAP 2021. My name is Doni Firman, so I will lead this session, and then let me introduce, and we have honor to have my co-chairman, Dr. Rajagopal from Brunei Darussalam. Hi, Raj.
Hey,
and then also we have distinguished panelists and also acting as speakers, Dr. Suko Adiarto from Harapan Kita Jakarta, Dr. Arwin Saleh also from Harapan Kita Jakarta, Dr. Hafiz from Makassar, and then Dr. Sodiqur Rifqi from Karyadi Hospital, Semarang, Java, Central Java, and Dr. Fauzi Yahya from Hasan Sadikin, West Java. So let's start to the our presenters, and then I would like Dr. Raj to introduce our first speaker. Please, Raj.
Thank you, Doni. It's a real pleasure to be here. I'm looking forward to the session. I've had a chance to look at some of the cases, and they're all brilliant. So our first speaker is Dr. Arwin Saleh from the National Cardiovascular Center, Harapan Kita in Jakarta. Is talking to us about a hybrid approach to LAD CTO. It's labeled as Tumbles PCI CTO LAD. Dr. Arwin Saleh.
Hello, everyone. My name is Arwin Saleh Mangkuanom. I'm from Jakarta, Indonesia. This time, I will bring a case about the hybrid approach of PCI CTO of LAD. This is the 66-year-old woman with stable angina with risk factor of hypertension and family history. She already done for PCI in 2017. Each of its her artery, one dash in LAD, one dash in circumflex, and one dash at the RCA. So this is the diagnostic angiography. We could appreciate that there is a disease start from the left main artery, which is already stented, and then CTO at the ostial of the LAD. If we could appreciate that from this right-hand side at the spider view, there is a stumless of the LAD, ostial LAD. So this is my PCI strategy, and if we calculate the GCTO score is 3, which are from the spider view, the stump is blunt, and the length over 20 millimeter, and this is retry lesion. This is the algorithm of PCI CTO by Brilakis from 2012. We could use it for my case. This algorithm shows that for the CTO strategy, we have to use a dual injection artery. And also use a dual of the guiding carriage of this artery. So we could see if there is an ambiguous or proximal cap. How about the distal target, and how about the collateral for intervention, and how about the length? And this algorithm also over us to use antegrade or retrograde wiring escalation, and also antegrade or retrograde dissection re-entry. Since we don't have a string ray and crossbar, so I will use wiring antegrade or retrograde escalation. This is, I try first with Fielder XTA with a single lumen catheter on the left-hand side, but of course it fails. Then I use a double lumen catheter with Gaia third, and also fail. I puncture the ostial of the ostial LAD. Only on using Conquest Pro 820, I succeeded to puncture it, but always go through the false lumen of the LED. So I already took about 20 minutes, so I changed my strategy to retrograde PCI. I take a Sion wire to serve over the septal branch, and surprisingly, the wire is going through to the maybe about 10 millimeter over the ostial, surprisingly. So it was very easy to cross it. So maybe the length of the CTO is not over the 20. And then I escalate my wire to Gaia 3rd. And because this is the long way to the ostial LAD, the Gaia is lose his strength to puncture the tightest of the stent strut at the ostial LAD. So I have to escalate again with the Conquest Pro A20, and finally my wire can go through into my guiding catheter at the antegrade. But after that, when I use my balloon trapping technique to push my micro, my GR catheter is kicked out and my XB guiding is sucked in. So it caused hemodynamic instability of this patient. The BP was dropped to 63/40 and patient felt chest pain, dizzy, and vomit. And after that, I have to lose my trap. I have to deflate my balloon at the trapping of the XB guiding catheter. I lost my grip. So sorry. So after that, I have to decide to use antegrade approach using Fielder XTA and my single lumen macro catheter. And luckily, my XTA may be going to the last puncture from the retrograde approach. And after that, we could see that my XTA successfully going into the distal LAD, and this is tip injection of the micro catheter filling the distal of LAD. So I start with 1.5 balloon for predilatation, and then 2.0 balloon, and then I start kissing balloon for predilatation, NC 3.5 at the LAD and NC 3.0 at the circumflex. And then I use a DES 3038. I deploy at the 12 ATM at the proximal to mid LAD. And I continue with second DES 3.5 20 millimeter. I deploy at the 18 ATM. And then I recross to the circumflex, and then kissing balloon. And then I end up with pot with 3.5 NC. I inflate up to 20 millimeter at 20 ATM. If there is a contrast striping there at the septal, but after we observe there is no complication, and this patient was discharged at the next day. So this is my conclusion. Dual artery access and guiding catheter essential in CTO PCI, and the hybrid approach to CTO offers the opportunity to treat more complex cases successfully due to its flexibility. Crossing old CTO stent is very challenging, and retro wire balloon trapping give us a good grip for pushing retro micro, but always be cautious as it may cause hemodynamic disturbance. Thank you very much.
Thank you very much, Dr. Arwin. So that's a great case. I mean, so many different techniques, and I particularly admired your choice of wires at each stage. I think there was a good escalation, and you were not shy of using, more challenging wires to get through. I think ostial LAD is very difficult. I think, ostial CTO and univascular is very difficult. Have you had any experience with the supercross microcatheter? Or it's one of those angled microcatheters. I found that sometimes useful to treat ostial CTOs. It's got a bit of an angle, and you can actually point it towards the ostium, and then you can start off with a PT2 and then escalate to a Gaia. That's an option sometimes in ostial lesions. But let's hear from the panelists. We have Dr. Sodiqur Rifqi here. What do you think of the case, Dr. Rifqi? Would you have tried anything differently?
Maybe Rifqi has some trouble with this.
So we have Fauzi is here. One of the, my favorite operators. Fauzi, what do you think of the case? What did you like about the case? Let's start with that.
Yeah, it's a very tough case actually. So, Dr. Arwin, did you do antegradely? It turned up to do antegradely, right? Because
Yes.
I see. So what can we learn when the catheter is guiding catheter kick out? What happened is it? Why it happened?
Because when I pull my micro catheter hardly, my GR from the retrograde is kicked out because I push my micro. And while I push my micro, because I trap the conquest at the antegrade guiding at the XB is sucked in. Because when I, So, and we could appreciate from the diagnostic, there is also the disease is start from the left main. So maybe the size of the left main is maybe bigger, little bit bigger than my XP. So that situation make hemodynamic disturbance.
Okay, I think for the ostial part, which is thumbless like this, it is recommended to use IFOS to guide where is the puncture site. And when we do from retrogradely, we have to be watch our wire, because when the wire go sub-intima and go all the way to the left main, so it's going to compromise the circumflex. That's the real problem that's going to have a hemodynamic compromise. But you did very well. So what do you use IFOS? Did you use IFOS for left main stenting to have such a insight? How is the size of the left main?
Yes, I agree with you. I should use IFOS, but because of this disturbance of her hemodynamic, so I end the case with the Stent pot and kissing balloon at the left main circumflex LAD. Yes, I agree with you. We have to be careful for retrograde surfing wire. So I use Sion wire, floppy wire, from the PL go through the septal and then the proximal LAD. So hopefully that floppy wire could not go into the subintima.
No, I mean when the wire go to the distal part of the distal caps, and the wire going, that is potentially go to subintima and all the way to the left main. So it's potentially compromise the circumflex.
I see.
We are concerned. Thank you, Dr. Arwin.
Thanks. It's a very, I think that it's a challenging case, and I think,
Yes, right.
We can get into difficult situations, and it's good that you handled it so well and got a very good result in the end, and great points by Fauzi there. All right, I think that brings us to the end of the first case, and we'll move on to the second case. Doni, would you like to introduce the next speaker, please?
Thank you, Raj. So the next speaker will be Dr. Suko Adiarto, my colleague in my hospital. So he will present his case regarding the peripheral intervention, totally occluded SFA with calcified distal segment, endovascular treatment. Please, Suko.
Thank you, Dr. Doni, for the opportunity. I would like to share my case about totally occluded SFA with calcified distal segment. So I had a very challenging case, at least for me. So I'm looking forward to learn from you about this case. So I have nothing to disclose. And this patient is a 83-year-old male with diabetes, with chronic kidney disease, with creatinine of 4.3, with ischemic rest pain and dry gangrene. So ultrasound shows totally occluded and calcified SFA with ankle brachial index of 0.3. So we did not do a CT scan because of his creatinine levels, and go directly to angiogram and presumably do PTA after seeing the anatomy of the peripheral vessels. We are using CO2 contrast media to at least minimize the number of contrast, conventional contrast that we were using, because the creatinine level is 4.2 and 4.3, and the patient is 83 years of age. So this is the initial angiogram. We did the crossover approach from right femoral artery with GR catheter. We can see that even from the iliac artery, it's already stenotic and calcified, quite a long lesion there. And we managed to cross it down below and see the, this is CO2, that's why you see the lack of contrast flow. And we'll see, initially we thought this is the SFA, but after the next angiogram, then we will see that this is actually the profunda. So totally occluded SFA. So we made another angiogram with a different angle, then we'll see that the big one that we saw just before was actually the profunda, and this is the SFA. Actually, this one, the small stump, is the ostium of the SFA. And we make a distal, quite a nice distal runoff here. The distal SFA is quite preserved. So how to cross? Normally we would try the antegrade intraluminal approach first, but when we fail, we usually turn to subintimal approach. And when it's failed, we're gonna do a retrograde approach. And this is the algorithm that showing step-by-step approach and how to do intervention in the SFA lesion. We can do the antegrade first. Subintimal crossing, if we are not successful, then we can try a re-entry device if we are not successful with conventional device, but we don't have the re-entry device here. Retrograde from tibio-peroneal access, that's quite kind of thing that we have to master in the future, because we are still learning to do that. And in order to do the card and safari technique, we have to get the retrograde approach somewhere from tibial or distal SFA. So we tried antegradely here, but failed because to our surprise, we didn't know that this patient has been stented before. That is why the intraluminal, re-entry into the through lumen is difficult because there is a stent here. So re-entering distally to the stent would look awful, because we would end up using two parallel stent, which is not good. So we try distally, as the algorithm show. We would like to puncture distally directly to the SFA using calcification and stent as the marker. But we also failed to do that. Look at the calcification here. We puncture directly into the calcification. But as you can see there, it's very hard. So even the puncture needle was bended because of the hardness of the calcification. So we fail. We were lucky that the surgeon was around. So I was asking him whether we can open the surgically to expose the distal superficial femoral artery. Actually, he did. He opened up for us to expose the distal superficial femoral artery. But what happened was that we cannot puncture even after we expose the femoral artery. The calcification must have been very, very hard. So what we did was to look back again at the angiogram, and now we realize that there's a collateral vessel here from profunda to the distal superficial femoral artery, which is quite favorable for crossing. So what we did was to approach that from the profunda here, with coronary microcatheter and coronary wire to place the microcatheter just below the stent where the stump is perforable. And to our surprise, we can cross that with quite a stiff wire, coronary stiff wire, and exchange the wire into the longer O14 wire. And also to our surprise that the collateral can accommodate such a large balloon. This is 4O by 100 balloon, and it's capable of inflating the proximal superficial femoral artery through the collateral vessels. So after several balloon dilatation, we recross from by antegrade fashion, then we can directly deliver our microcatheter here and wire afterwards and perform balloon angioplasty from above. It's quite a hard lesion there, and below you can appreciate the wire here from the collateral vessels. We delay removing it until after we secure the wire from antegrade approach. And this is finally the final result. This is the CO2 contrast. This is the proximal part, and this is the distal part of the SFA. So coming back again to the algorithm, so we need many kind of approach to cross the lesion of chronic total occlusion, and the more complicated it is, the more technique that we should master. And this is the number of approach that we have to master, and once we get more than one approach to open the calcified CTO, then the more likely we will get success to get the SFA totally occluded lesion crossed. So what I learned from this case is that retrograde approach is an essential part of strategy of treating peripheral CTO lesion, and a good collateral channel may be used to cross CTO lesion by retrograde fashions. Thank you. Looking forward to hear some points from you. Thank you very much.
Right, Suko, this is a very, very interesting, and then yeah, really, really happy to see you improvise that kind of complex procedure. So, I must admit that I'm not doing peripheral intervention. So, regarding the using the collateral things, you know, in the coronary intervention, we have requirement for the collateral, which suitable, which collateral should be suitable for the intervention, like Arwin's case. So, what about in peripheral? Is there any requirement of any ideal collateral for intervention?
Yeah, thank you, Dr. Doni. So ideally, it must not have been very tortuous, quite a straight collaterals, and in most of the cases, the wire is not used to cross it, but just to put the give an idea of how to cross it from antegrade fashion. But in this case, the collateral is quite big, so I was confident that we can approach it from below. And moreover, the stump is more favorable distally than proximally, so we can cross it from below. It is even large enough to accommodate 4.0 by 100 balloon. So actually quite an ideal collateral to do intervention from.
So, yeah, no, that's great. I mean, we tend to do some fistula interventions where some of the collaterals are as big as the vein itself, and we end up passing, sometimes opening up the collaterals for flow. Can I take a step back, Dr. Suko, and ask you about your anti-grade approach? I wasn't quite. What wires did you try? Did you try just the normal overnight wires like V18, or did you try any O14 wires? Did you have a microcatheter? What was your technique for the antegrade? Just wondering, how far you went before switching to the retrograde approach.
Yeah, we tried the 018 wire with the backup of microcatheter. The name?
CXI?
No, we don't have CXI here in Jakarta. We have Rubicon. The only microcatheter we have the Rubicon from Boston Scientific, and I escalated from V18 to the CTO wire from. No.
Asahi.
No, we don't have Asahi right now. The one from Boston as well.
Okay, no, yes. Okay.
Yeah.
It was a good effort, yeah.
Yeah, so we cannot cross, so we decided to turn to subintimal angioplasty, hoping that we could re-enter just above the stent, but we were unsuccessful.
I think we are just running out of time. So one last comment before we wrap up. I think it is really good that you thought of working with the surgeon. I think this day and age, if you're doing endovascular procedures, I think it shouldn't just be the vascular surgeon trying on their own, or the interventional radiologist or the interventional cardiologist. There's just too much going on. Yeah. I think it's a really good idea to work in synergy with the surgeons. They know the anatomy. We know how to pass wires and balloons. I think if you work together, likely to get best results. So congratulations on doing that.
Thank you, Raj.
Thank you. So I think we'll move on to the next presentation, Doni, if that's okay.
Sure, Raj.
Right. So the next speaker does not need any introduction. It's Dr. Fauzi Yahya from Bandung, Jakarta, and is going to present a very interesting case on managing a complex ISR stenosis with OCT guidance. Fauzi, floor is yours.
Okay, thank you very much. I'm going to share a quite challenging, complex in-center stenosis for the patient who had already 12 to 15 years old before got a stent. So I have no disclose. So this clinical history, 80 years old senior physicians present to our hospital with a history of crescendo angina. Cardiac enzyme was normal. His risk factor are diabetes, hypertension, and dyslipidemia. He had a history of ischemic stroke with minimal squeal. He has a moderate renal dysfunction and reserve LVEF. He underwent multiple PCI since 2005. The proximal LAD got double overlapping 3 mm first generation DS. And in 2011, he had ISR, so got drug coating balloon. In 2012, he got another one DS at the Ramos. So this is the cranial view of coronary angio. You can appreciate he's demonstrated the diffuse disease of LAD with the sluggish flow. And you can see here there is a subtotal of ostial LED. And there is a re-stenosis of the pre-existing stent at the proximal LED. Fluoroscopy image demonstrated that 3 mm stent that pre-exists look well expanded and no stent fracture noted. This big ramus was stent was patent. There was a narrow angle between the LED and ramus, and RCA revealed no significant stenosis. There was collateral CC1 to the distal LED. Based on this stenosis and bad distal runoff and clinical complexity of the patient, CABG, I think, was not a better option for this kind of disease. And moreover, the patient turned down a CABG option. So we decided to do PCI. Current algorithm and guideline of instant restenosis recommend to do intracoronary imaging to determine ISR mechanism. And the cause of ISR could be mechanical, biologic, or mixed. OCT, which has a better resolution, is useful to identify the morphology of ISR lesions, which lead us to determine appropriate treatment. We knew that the vascular response of ISR lesion to balloon angioplasty might vary depending on type of the ISR lesion. So following pre-dilatation using 2.0 millimeter balloon, this is we perform OCT. The distal of the LAD show the diffuse disease. Some of segment was fibrotic. And the OCT reveal high-grade stenosis. You can appreciate here. And there was a variety of signal intensity of the OCT. And it, I can stop here. You can hear. This is a deep part of the neo-intima showed calcified tissue, and the superficial part of the neo-intima was layered tissue. So this is consists of collagen and extracellular matrix. And the ostial part, this is a disease of the LAD. So I think we cannot stop the stent or whatever we at the ostial part. For such situations, this is the stent, pre-existing stent, looks expand well. We measure the pre-existing stent. The 3.0 stent looks good from the distal to the proximal one. So the problem, the biological mechanism of this instant restenosis. And this is because of the different tissue pattern. Based on this heterogeneous neo-intimal tissue, we can say this is the neo-atherosclerosis that make this instant restenosis. So, well, we are encountering complex setting situations, complex patient who is octogenarian, diabetic with vascular disease, which is stroke, CKD, and CAD, complex anatomy. You can appreciate diffuse disease LAD involving ostial LAD and narrow, big angle ramus branch. And complex lesion, it was very late recurrent ISR, and neo-atherosclerosis was confirmed by the OCT. So we decided to use warfarin, a cutting balloon, to have aggressive lesion preparation to get good luminal gain. The cutting balloon size with the OCT to achieve effective lesion expansion by reducing the hoop stress. We try to cut as close as possible to the stent strut. Following cutting balloon at the stented segment, we are concerned at the distal part. So we are dilated the distal part of the LAD using 2.0 15 millimeter balloon. The problem is where we should land the stent, because we cannot use a drug coating balloon for such a diffuse disease involving the ostial part of the LAD and go all the way to the left main. So we are plan to put the stent, but where is the landing zone of the stent? We decided to put the distal landing zone close as the distal stent edge here, all the way to the mid of left main. Another problem which we have to settle is how to protect the ramus, because as you appreciated before, this is the ramus and the LAD was a narrow angle, so we avoid the compromising when putting the stent to LAD to left main, putting the compromising of the ramus. So we use protect the ramus using modified balloon technique. We put 3.5 millimeter DS in left main LAD and 2.0 balloon attached at the stent at the ramus. And stent and balloon deployed simultaneously at 212 ATM. And then following there, we did a part and distal rewiring to ramus. We are using a 4.5 NC balloon to do part. And gel wire as mark of the proximal strut. You can see here, this is the gel wire, and this is the rewiring go to the distal strut. And then following that, we did distal optimization technique using 3.5 NC balloon, and then followed by kissing balloon using this 3.5 balloon at the LED left main and 2.0 millimeter balloon from the ramus to the left main, and did a report afterward using the same balloon. This is the OCT post OCT. Looks as you can see here. This is what you can see here, dissection until the media part. I think this is a major dissections. But at the stent looks well expanded and well opposed. I think because we did a lesion preparation well before putting the stent, and did a distal optimization and proximal optimization technique. This is a medial dissection at the distal part. So we decided to put another DES 2.25 millimeter overlapping into the previous one, and followed by post dilatation using high pressure balloon from this kind to the middle part. And this is the final result. So the flow is a good symmetry flow, no compromise to the ramus. So we can conclude that neoarteriosclerosis likely plays an important role in late ISR. Appropriate tools and strategies should be selected in dealing with challenging lesions associated with ISR. OCT is useful to identify mechanism of ISR, to inform the appropriate treatment, and to confirm effective treatment post-PCI. Thank you.
All right. Okay. Thank you, Fauzi. It's very tremendous, and then we learned so many things regarding your case. And then this is very complex, very old, and physician,
yes,
our
yes,
senior
right.
as well,
yes,
and also have something like that. And then I know the most challenging, I think, because this is very diffuse stenosis, right? So distal landing zone is very important.
Yeah, right.
So this is that's how you ended with the medial dissection, and then you must stand. I think it can be predicted before that. So
actually, Dr. Doni, actually the distal landing zone at the stented segment.
All right.
But I dilate the distal one using the balloon, but at that time it's dissected. So the distal landing zone at the stent segment. But afterward, I put another stent because of this digital.
All right. So any particular reason you put another stent, or you
because of
no. I mean I think of DCB or something like that. Because
no, I don't think so. Because of distal stent, such a major dissections.
Sure.
That's
sure.
yeah.
I agree with that.
Concern, yeah. Okay.
Yeah, yes. But the more distal, based on the OCT, the lumen is also very small. So
yeah, right,
there's concern about create another dissection in distal. But you did it very beautifully. So Raj,
thank you very much.
Any other?
No, that's a great case, of course. Can I ask a controversial question, for the panel? Firstly, you said very clearly in this situation we have to put another stent in the proximal LAD in the ostium. We cannot just do a DEB. Can I ask if there is anybody in the panel in this situation with the ISR extending back to the ostial LAD? Is there anybody who would just do a DEB? Of course, with a lot of predilation, you did Wolverine, maybe NC. Is there anybody, Doni or Dr. Rifqi, anybody who would just do a DEB? Yeah.
Well, for the proximal one,
there's a stent. There's metal already there. There is already a stent. I'm not sure if I would do it, but I'm just asking, is it an option to avoid a second layer of stent?
Yes, that's a really intriguing question. But if you see from the Fauzi's OCT, you can see there's a very diffuse of the
There's a lot of tissue there.
Yeah, a lot of tissue there.
Agree.
So I don't think that the DCB can maybe we will come back the next 3 months and then asking for doing another procedure.
Different part of the algorithm.
Yeah, another comment from the other panelists, maybe Rifqi or Hafiz.
Yeah, I think it's very challenging question. But in the situation where the size of the LED and left main is very different, so I think I will consider the DEB, because putting stent at the LED with much different to the left main, it will be difficult to do port at the left main. So in this situation, maybe DEB is the choice to be considered. Yeah.
Thank you. Anybody else?
Thank you, Doctor. Congratulations, Dr. Fauzi. It is very complex procedure, a lot of techniques, and the result is very beautiful. And of course, OCT is the guideline in ISR procedure. It can give us a lot of information, neo-intimal characteristic, and one of the important information is 3D reconstruction of the stent. That's why we can see clearly the main problem in ISR with OCT. Dr. Fauzi, I just want to ask about using AC balloon in kissing balloon technique. Is it your strategy to prevent ostial branch dissection, or do you have any other consideration, Doc?
You mean a modified gel balloon? Because this is your question, right?
I mean, please, in your slide, you did kissing balloon, one main vessel using NC balloon, and then in the branch using SC balloon. Do you have any consideration of using SC balloon when you did kissing balloon technique? Thank you.
Yeah, yes, right. I think we can use the previous balloon when it can go through the strap. What the important thing, how high you can go. That's important. And we use the balloon to modify as a modified balloon. So we then use it as a kissing balloon. The main goal of the kissing balloon is to place the carina at the middle. So that's the important part. And regarding the dark coating balloon, as you mentioned, Raj and Dr. Rifqi concur to use a drug coating balloon. I'm quite concerned that this is an ostial part, which have different characteristics with the other part of the vessel. This is most likely this is smooth muscle there, smooth muscle cell there, and so recoil effects. So I don't think the drug coating balloon play a role at that part. Moreover, the plaque burden is very huge. So I think, as Dr. Doni mentioned, that I agree that we are putting the stent all the way to the left main.
All right. Okay. Thank you, Fauzi.
Yes. Thank you.
Sorry. Due to the limited of time, so we must move to the another speaker. So Dr. Sodiqur Rifqi will present his case. The title will be rotational atherectomy in heavily coronary calcified lesion with aneurysm. Please, Dr. Rifqi.
For the time, and thank you for TCTAP accepting this presentation. I'd like to present about the case of rotational atherectomy in heavily chronic calcified lesion with aneurysm. I don't have any potential conflict of interest. The background is that heavily calcified coronary lesion with aneurysm is considered a complex lesion. The presence of coronary aneurysm and calcified coronary lesion is infrequent but not rare. It is seen in 0.3 to 5% of patients undergoing coronary angiography. And the use of percutaneous transluminal rotational atherectomy in this situation may be mandatory, despite posing additional risk that concern on procedure safety. It means high risk. This patient, Mr. Diaz, 58 years old, diagnosed with a stable angina pectoris CCS2 with CID risk factor dyslipidemia. And past history, stroke non-hemorrhagic non-STEMI in 2018 and about 1 year before, and successfully stented at RCA, failed to PCI to LED. Using two balloon, and two balloon was ruptured. One is scoring, and the other balloon was non-compliance balloon. So, and then this patient referred to me. The ECG shows sinus rhythm, Q pathologic at 3, and IVF others within normal limits. And the echo was still good with ejection fraction around 67. This is PCI 2018. This is a pre-stenting and then stenting, and this is the result of post-stenting. And this result is still good when we do the next procedure. And this is angio picture when we do the procedure. This LD, we see the heavily calcified lesion at the LED with 90% stenosis in between the first and the second aneurysm. This is the aneurysm, and we see here that the left main is still good, very proximal LED is still okay, and non-dominant circumflex with some stenosis at the ostium. And then I decided to use the 7 French guiding catheter, start with the floppy rota wire and then rota burr 1.25. Luckily, just with the second run, I can cross the lesion, and then I did the polishing run as well with the rotational speed around 160 to 170,000 RPM. And then I tried to do some pre-dilatation using the scoring balloon to 0.15 until 18 atmosphere. You may appreciate here that at the proximal part, or here, still some indentation. It cannot expand very well here. And then increase to higher balloon to 5. Sorry, this is the second balloon, scoring balloon to 510. I inflate until 20 atmosphere. We still see some indentation, and then do the non-compliance balloon inflation using 27510 to 822 atmosphere. You see here the first still some waste at the mid balloon, and then finally at 22 atmosphere, after more than 20 times pre-dilatation, the severe calcification crack. And then this is, I do some stent implantation, the first using the second generation DAS, 275 26 millimeters at until 13 atmosphere at the mid-distal, and then overlap with the second DAS, also the second generation DAS to 3529 at from 9 to 13 atmosphere, and then post-dilatation at proximal LED using non-compliance balloon 3.5 15 millimeters at 14 atmosphere. And then this is a result after post-dilatation. I think it looks good, well expand, and Dimitri flow, and also the circumflex is not occluded. Okay. And luckily that the aneurysm is disappeared. This coronary artery aneurysm was defined as a localized dilatation of more than 1.5-fold to the adjacent normal segments. And classification, if less than 5 millimeters internal diameter, it classified as small, and then medium 5 to 8 millimeters, and then the giant more than 8 millimeters. This is the gross specimen, this aneurysm, this the vessel, and then from the histology showing that the media is much less thin than in the normal vessels. So we have to be careful of the perforation in the aneurysm. And then this is some classification. This is a coronary pseudoaneurysm, which is only adventitia, no intima in media. And this is a coronary aneurysm, secular and fusiform. In this case, I think it's a secular form. And then there's this coronary ectasia, and this is a giant coronary aneurysm. In this case, this is a stable coronary artery disease, stable angina. But in the acute coronary syndrome, it can be thrombus developed here. And then if like this, it can create the distal embolization and sometimes may create a rupture of the aneurysm. Barbieri at the Future Cardiology 2020 showing that percutaneous transluminant rotational atherectomy is safe. He and friends presenting 6 cases that was performed using the atherectomy, and it was safe. And they give some advice in the absence of tortuosity, the extra support rota wire to get the optimal system stability. But I prefer to use actually just a floppy rota wire. And try to reduce bore vessel diameter to 0.5 to 165 and reduce number of passage in order to obtain only plaque compliance or plaque modification, but not plaque burden reduction. And then the non-compliant 1.1 size balloon should be inflated at low atmosphere to verify the efficacy of the atherectomy and to avoid the coronary dissection. In my practice, I prefer to use a bit smaller, but try to use a higher balloon, especially using the scoring or maybe cutting balloon. Second, higher dimension burr, when necessary, can be used. Usually no more than 1.5, 1.7. Use the conventional drug eluting stent, especially the second generation. The possible major complication, no reflow or coronary perforation.
So I think we already saw your very, very challenging case. And then looking at your case, your diagnostic case, I know the first challenge will be how to pass the wire, because it's very calcified, and then you have 1 or 2 aneurysm maybe, and then but you succeed, you're passing your wire. Congratulations. And then the second problem that you mentioned, that you deal with very heavy calcification, and then you need some balloon dilatation and finally crack the calcification. And then I can see that there is the most proximal one is look like very eccentric and maybe some nodule calcification. So before I ask to Dr. Rifqi, maybe I'll ask to Raj. So what about your threshold doing IVL in this setting? Are you doing anything else first? Because in Brunei you can do everything, right?
No, actually, honestly, when I was looking at this, I was very much thinking, could I do lithotripsy here? I haven't done a case with this kind of focal aneurysm. We have done lithotripsy in patients with, I think I shared on a different forum, a very ectatic RCA, very toxic-static, and it worked really well. We were able to, with some difficulty, pass the lithotripsy to the distal RCA. It was a 5 millimeter vessel. So we did lithotripsy with a 3.5 lithotripsy balloon, and then we did further dilatation to 4045 and did a DEB. So I haven't actually seen recorded cases online with an aneurysm, but I think it should be possible, and I think it should be safe. The challenge is, of course, whether we can pass the lithotripsy balloon through the lesion at all. And if it doesn't go through, and if not smaller, we run cases where we passed a small 1.5 or a 2N balloon. We did one last week to open up the lesion a little bit before passing the lithotripsy balloon. That might be something that might work here. And that might offer some safety as well. But of course, the rotablation worked really nicely here. But I think in the future, lithotripsy, IVL, could be an option in these cases.
All right, thank you, Raj. So is the another approach maybe from the other panelists, and then some question maybe to Dr. Rifqi, maybe Fauzi or Arwin or Suko? Hafid, please.
Yeah, Dr. Yeah, please, Dr. Arwin, please.
Thank you, Dr. Fauzi. I'm just wondering if you know, when you use a cutting balloon at the aneurysmatic, it's very scary and very dangerous. I'm just wondering if could we use a low speed of burst so we could gain more lumen area after the rotational atherectomy? Maybe Dr. Rifqi. Thank you.
Yeah, actually in my practice, I usually start with at around 160 RPM. A bit faster rather than starting with a low speed. I think it will take more time. And I think using the smaller balloon is, I think is safer, it's very safe. So some operator use a second burr, second larger burr, but no more than 1.7. Comparing to the vessel diameter. And in my practice, usually after using the rotablation, I like to use the scoring balloon or cutting balloon. Using the lower size compared to the distal vessel size. So I think it's safe and also reduce the risk of like plaque shifting to the side branch, yeah, and reduce the risk of the side branch occlusion because the concept currently is the concept of the rotational atherectomy is not debulking, but just plaque modification. Just reducing the calcium in the inner diameter of the coronary artery. So I think a kind of scoring balloon or cutting balloon may be useful to help the better expansion of the vessels. But of course, I prefer to use the smaller size, the lumen diameter of the vessels.
Okay,
thank
great.
you.
So,
Thank you, Dr. Rifqi. That's great point and very wise observations. I think we're running about 5 minutes over time, so I think we'll move on to the last presentation for this session. It's by Dr. Hafid from Wahidin Hospital, and he'll be talking about decision-making in a complex lesion. Dr. Hafid, please.
Okay, good afternoon, ladies and gentlemen. Thank you for having me in this program. Today, I will not present about complex case in the cath lab because I do believe that a lot of lecturer will bring it. Today, I would like to present about how to build a decision making with the title of ISR in non-ligament bifurcation, stent or not to stent. Coronary procedure has gone through rapid advancement throughout these years, from the first time POBA only to the highly complex procedure these days. However, the most crucial part of those advancements is the decision making. Generally, there are two mechanisms of ISR, the technical and the biological mechanism, and it's described very well in this picture. In 1999, during the BMS era, Dr. Roxana Mehran published her version of ISR classification, which was based on angiographical data, and it is very helpful for us until today. Then in 2019, during the DS era, Dr. Ron Waxman has renewed this classification by combining photomechanical and angiographical findings. This new classification is pivotal as a guide to form an accurate strategy to overcome the upcoming ISR. And this is the patient, a 60-year-old male patient with recurrent chest pain. The angiogram showed ISR in mid-LAD with the prior risk factors of diabetes and hypertension. The patient had history of prior PCA 10 years ago. He underwent primary PCA, but there were no data about the type of the stent, whether it is BMS or DS, nor its size. 1 year ago, the patient underwent PCI due to ISR. POBA procedure was done with additional implantation of one stent distal to the first stent. And several days ago, the patient underwent angiography in another hospital with the result showing ISR, then patient referred to our hospital. And this is the angiogram. An ISR was shown with subtotal occlusion in mid-LAD, at the bifurcation with significant occlusion in ostial diagonal. The baseline of this patient is recurrent ISR. Thus, the first step to do is identifying the etiology and neo-intimal characteristic of the ISR. Since the lesion is subtotal occlusion, the initial step taken is to create a pathway for IVUS catheter. Usually we use balloon to 015, then we inflate until 6 atm, then we perform IVUS. Then this is the IVUS data. Left main MLA of 21 until 22 mm square. It is 5.5 mm vessel. Proximal LED MLA of 9 until 10 mm square with the EAM of 23.8 mm square. On the down left, we could see very tight neo-intimal with MLA of 2.3 mm square with a minimum stent area of 5 until 6 mm square. It is 2.5 until 3.0 mm stent. And the EM area of 14 until 15 mm square, around 4.0 until 4.5 vessel. On the proximal and distal part of the stent look undersized with the MLA of 2 until 3 mm square with the MSA 5 until 6 mm square with the actual vessel size EM of 12 until 13 mm square. By this imaging, it is shown that the stent size chosen in the primary PCA was undersized. It is also showing the virtual histology, a new intimal pattern of heterogeneous type. And of course, OCT is the gold standard of imaging in ISR identification. It can show new intimal ISR and 3D reconstruction of stent design clearly. But it doesn't mean that IVUS is no use in the management of ISR. Despite being less clear than OCT, quantitative and qualitative data provided by IVUS is vital in assessing ISR etiology and the type of neo-intimal. In this case, the multiple color of green, yellow, and pink means that the new intimal type was heterogeneous. Plaque modification strategy in ISR is very crucial. A correct device selection will provide us with the next strategies option. The REDUCE 2, 3, and RESCAT trial did not prove that cutting balloon is superior than NC balloon, but the use cutting balloon or scoring balloon as initial weapon in treating ISR is more advantageous since it requires less balloon, less stent, less slip risk, and lower rate of uncontrolled dissection. Based on the result of MLA 2 until 2.5 mm square with the lumen diameter just 1 until 1.5 mm, so we decide to use scoring balloon 2.5, then we inflate until 12 atm. Then we upgrade with NC balloon 3.5, we inflate until 18 atm to grow the minimal stent area. We did not use the larger NC since we did not have any data of the previous stent type. Therefore, we couldn't approximate the maximal stent expansion beforehand. And of course, the 5 years prognostic effect that compares single versus dual stent yielded similar result. meaning that a non-left main procedure, the complex bifurcation compared to professional, resulted in similar outcome. And in this angiogram, we can see that the diagonal pins less than 80% and length less than 10 mm. So it is unnecessary to perform stenting on this diagonal. Then we just open with SC2015 inflate nominal. Then of course we have to POT with NC3515. Then we inflate 18 ATM in the main vessel. Then this is the subsequent angiogram. It's quite nice. Then this is the IFUS post-lesion preparation. We can see that the MLA was growth 7.5 until 8 mm square, and then the stent grew 25 until 30%. Then the average diameter of the stent increased until 3.5 mm. Then the MSA average increased 10 until 11 mm square with a minimal residual stenosis of less than 10%. We are quite happy with this result. And what's next? Ron-Waxman classification for ISR gives us very clear pointer. In this case, we conclude that the main problem was the mixed pattern. Hence, after lesion preparation, either DES or DEB is fit to go. Then, so what's next? Waxman suggestion aside, ASJ also placed DEB and DES in the similar category 1A. And trial and large-scale studies regarding ISR also stated that DEB and DES yield similar outcome with similarly promising clinical result. Notably, the selection of DEB and DES should be adjusted with the short-term and long-term payload ability. For hospital without good payload devices such as rotablation, vascular brachytherapy, or coronary laser, the dual layer strategy, I think not the best choice to perform. That's why we option for DEB for this patient. And this is the final result. For the conclusion, decision-making is the most difficult step in PCI. Intracoronary imaging provides significant overview that will guide us in selecting an appropriate device and give a broader strategic option. POBA only is no longer an option in ISR treatment, and DEB is still relevant and reliable to use in the era of ISR, but always use imaging before we use DEB. And the last one, vessel sizing and stent size selection are very crucial in primary PCI, seeing that we are facing mechanical and biological undersizing due to coronary growth post-MI, which is the risk factor of ISR. Then we wish for the panelists and moderator to give some tips and tricks in vessel sizing during primary PCI, since it is still a challenging thing in the cath lab. Thank you very much.
Thank you very much. That was a great case. I think it made a lot of important points about a situation like this, intracoronary stenosis. Like Dr. Fauzi did earlier, you stressed the importance of using imaging in decision-making. You also had a bifurcation. You made the right decision not to go for a two-stent strategy and complicate things. And I think DEB is very wise. Unfortunately, we are out of time here, so we cannot have a detailed discussion. So I think I've been asked to wrap up the session. I think it's been great. I think we've had some great cases here. We've had CTO cases of both coronary and peripheral. We've had some great imaging here for both IVUS and OCT. We've had complex cases, including rotablation. Enjoyed the discussions. I think we've learned a lot from each other. So I think we'll have to draw this to a close. So I would like to thank all the speakers and the panelists for contributing to this fantastic session. I would like to thank Dr. Doni Firman for inviting me to join him and TCTAP. And I wish everyone a really good conference and well, safe times wherever you are. Doni, would you like to say goodbye?
Yeah, okay, so I think that's all, and then Raj already wrap up all the session, and then stay safe everybody, and stay healthy. So thank you for the TCTAP committee. Bye-bye. Goodbye.